At the outset, I would like to thank the organizers and Amita Vishwasar for this opportunity and this interesting session, which we'll try to make even more interesting. It's a kind of a two-log where myself and Dr. Soumik Goswami, very revered senior to me, Soumik, we will be talking about enhancing glycemic management through innovative insulin therapies. We know insulin has become integral to the management of type 2 diabetes, and there are newer insulins, newer combinations of insulins which give us a better profile in terms of type 2 diabetic patient. So it will be like a kind of interaction between the two of us, and we will take you through this journey on innovative insulins. Let's begin with a case scenario. It's always good to discuss cases in a gathering of clinicians. We have this case of Mr. Amit, who is 49-year-old, a hypothetical case, an engineer by profession, and has a BMI of 27, which is clearly in the obese range. His blood pressure is also elevated, 142/86. He has diabetes or type 2 diabetes for 7 years. He has a family history of diabetes. He does not exercise like most of our diabetes patients. He has an HbA1c of 9.5, elevated fasting and postprandial glucose levels as well, and he is on a combination of oral hyperglycemic agents, metformin, glimepiride and empagliflozin. So this is what this patient is like. A prototypical type 2 diabetic patient walks into your clinic this evening, and what are you supposed to do with this? So Soumik, what do you think should be next for this patient of such a profile, whether you want to add another OAD to the already 3 combinations that he's taking, or you want to switch him to insulin?
There are certain things which are heart cells and certain things which are brain cells. So if I go by my heart, I might possibly try to increase the dose of glimepiride, add a DPP4 inhibitor, or rather than a DPP4 inhibitor, if money is not a problem, might even consider oral semaglutide or an injectable tirzepatide. But if I go by what my brain says, if I go by the published evidence, possibly adding the insulin would be a more guaranteed way of reaching a glucose target. Although this data is a bit dated, it's 2007 when the DPP4 inhibitors, the SGLT2 inhibitors were not available commercially. Even today we see that those with somewhat longer standing diabetes, if you go on adding oral anti-diabetic agents, there's decreasing gain. With every additional OAD, the amount of A1C reduction starts coming down. So if I were to listen to my brain, look at the evidence, go for a guaranteed A1C reduction, insulin would obviously be the answer. So the question would be, what are insulins available given a patient like this that we are talking about?
Thank you, Soumik, for taking us through this choice between an oral drug, additional oral drug and insulin, and we are now probably on board that an insulin will be a better add-on, especially considering the fact that he has an HbA1c of 9.5, which immediately qualifies for insulin therapy. And insulin can be given in various forms. Basal insulin is what we often start with, unless the patient requires more than 1 shot of insulin a day. And for the basal insulins, we know these are the commonly available basal insulins in Indian market today. The first generation ones, the most commonly used one is Glargine 100 IU and Detimir, which both of them came around 20 years back, but Detimir has fallen back and Glargine is way ahead beyond Detimir because of the pharmacokinetics, etc. And the new generation insulins, or the ultra long-acting basal insulins, Glargine 300 and Tresiba, both of which are relatively new and offer better flexibility, better glycemic control and better pharmacokinetics compared to the 2 basal insulins, the older ones. Why do we want this newer generation or the beyond the first generation analog insulins? Both of these are analog insulins, but we have moved beyond a first generation to a second generation analog insulin. We moved from NPH to analog, and from now analog to another analog. Because the promise of this 24-hour coverage with these basal insulins was not met. It was a false promise that was made to us that Detimir, that Glargine 100 IU will cover for 24 hours. They fall short at 16 hours, 18 hours, max to max 20 hours. There is extreme glycemic variability with single shots of Glargine, even with 2 shots of Glargine if given for basal insulin. Fixed dosing, we often write in our prescriptions, injection Glargine at 10 p.m. daily. We often write that, and we tell our patients to take that on the same date, same time daily, a little plus minus is allowed, and they are not truly peakless. That is one important factor, because peakless insulins are not supposed to be causing hypoglycemia, but we often encounter patients who are only on glargine but come to us with hypoglycemic episodes. So these are the unmet needs with the initial generation of basal insulins, and thereafter that is why we are looking for the newer generations. So my question goes back again to Soumik. From the available basal insulins, the first and second generation, which basal insulin would you consider for this particular gentleman in our case?
So again, if you talk of basal insulins, theoretically possibly the best basal insulin after our endogenous insulin would be using an insulin pump, but again that's something impractical. So we have to listen to our heart and our brain, and we have to decide the best available basal insulin, which of course is a degludec. Because again, if you look at variability, the change over 24 hours, degludec gives you a reasonably steady 24-hour profile. If you consider U100 glargine, about 60% of it acts in the first 12 hours, 40% in the next 12 hours. Even with U300 glargine, it's about a 55% acting in the first 12 hours and a 45% acting over the next 12 hours. So is there any head-to-head data that one gives you some advantage, like degludec gives you some advantage for U300 glargine? We have this real-world data from the United States, about 4,000 individuals propensity matched, which showed that at the end of 180 days, about 6 months of follow-up, there was somewhat better, statistically significant HbA1c reduction with degludec compared to U300 glargine. And even with better HbA1c reduction, the rates of hypoglycemia were lower with degludec compared to U300 glargine, and this was in a real-world setting. This study also showed that the rates of discontinuation were higher with U300 compared to degludec. The reason possibly being lesser hypoglycemia with better glucose control led to higher continuation rates with degludec. Now we also know from the addition trials, if you put them together, when you are using U300 glargine, you need a 20% higher dose compared to glargine, and that adds to the cost, that adds to the volume of the injection. If you look at flexibility, because that is what Dr. Pankaj was also referring to when he was comparing these insulins, degludec is a much more flexible insulin. Actually, you can use it at any time of the day within 24 hours, and the next day at any time of the day within 24 hours, and you get nearly similar efficacy without an increase in hypoglycemia. You can give 2 doses as quickly as after 8 hours and as lengthily or as distantly as after 40 hours, compared to only the 3-hour flexibility that U300 glargine gives us. So the next important question in our patient, or in any patient, how do you initiate degludec?
So once we've again come to another conclusion that this patient requires insulin, this patient is suitable for a basal insulin, and this patient may do best with degludec or Tresiba for today's case. So how do we shift him from whatever he is currently on to degludec insulin? If he is insulin naive, like this patient of ours, plus minus a GLP-1 receptor agonist, a 10-unit daily Tresiba or degludec is recommended as initiation. That can be titrated as per our follow-up requirements. And if the patient is on a GLP-1 receptor agonist like a semaglutide, a 20% reduction in the dose of Tresiba from this 10% may be suitable for this patient. For the other scenarios, if this patient of ours was hypothetically on a basal insulin like a glargine or a detemir, you will convert to the same dose of insulin in terms of degludec. If it was 10 units glargine, 10 units of degludec. If he was on a combination like a basal bolus regime or a twice daily premix regime, then get the long-acting insulin out of that regime and equal again a similar component of long-acting insulin in terms of degludec. If the patient was on a basal bolus regime with glargine U300, which requires a slightly higher dose, as Soumik was pointing out, then for the 20% dose that was increasing, I would decrease it by 20% again for the Tresiba or the degludec that would be prescribed in this case. So the case, we've finally decided to give him degludec insulin, and the case comes back to us after a period of 3 months of initiation of degludec. Look at him again. He is currently on degludec 14 units per day. His HbA1c has improved significantly, 1.3% over 3 months. His fasting and postprandial glucose levels are also within acceptable range. And we've advised him to continue with this regime and follow